Can you start, sir?
Yeah. Aravinda. Mm, Okay. Mm, Okay, we can start. Mm.
A very good evening to one and all present here who have joined us for today's session. Today we have Dr. Prithviraj sir, Junior Resident, Department of Pediatrics, Badwan Medical College, West Bengal. We'll be having an exam-based rapid revision session for pediatrics. Thank you, sir, for joining. The session is yours.
Okay. Uh, Good evening to one and all present here. So today we are. This is a generalized. It's a generalized. This session was planned in a short period of time in order to give a small to for guiding you for preparing for this your supplementary exam for Tamil Nadu Medical University. So I will be just covering a few important topics and how to approach. So basically, it would be a talk, a short video of around 45 minutes, where we will be discussing how to approach the question that has been asked in the exam and how to answer it. And if any question which is difficult or it's puzzling, we will also discuss how to answer that question with the knowledge you know on that particular topic. So with that small introduction, I will be going uh, with the topic per se. Okay, so normally, yeah, around that 16th, I guess 17th, yeah, 16th May, and this time the results are not that good, and few of the people you just missed uh, getting to that level by just 0.5 or 1%. So the marking system for this year, because according to the CBME, is somewhat jeopardized. The way the passing criteria was initially present, and as a result, even those people who got mark in the passing mark in the theory and as well as practical, but in in totally in percentage, they just got zero point 0.5 or 0.25% behind the average percentage that has to be given for getting passed in that particular subject. Because of that, only most of the people couldn't clear this exam. So I would rather say that it was glitches in the recent new examination pattern. So I would say that don't worry on that. So you have another by few days for the supplementary exam. So you are already gone through all the topics. So you don't need to read as a new. So you already know what you have already read, but for this time period, since it's kind of a stress period, so just go through the topics which you are very weak. Like there are few topics you are thinking that this is very difficult to understand, or I have to spend more time even in before exam, that is in the actual exam when you thought that this should have been covered in detail. Go with that topic first right now. On those topics you already know very well, or are very and for you you have revised it for a lot, then I would suggest that you should go with that topic at last. Initially, those topics which is very important, but you didn't revise very well, or you don't understand the topic, then give time for that particular topic, and then go for the other topics. So this is the way you have to prepare for the exam. And in so I will be discussing on the pediatrics. So in pediatric neonatology, if you are following the books, standard books for UG, it's OP guide. The recent edition is your ninth edition. So I assume that most of you follow that book. If so, well, or else if you're following some guide, like there are a few guides like your prep ladder or marrow notes, then you have to go through that note. So whatever you prepare for your primary preparation, that is for your actual MBBS exam that you wrote in your March, April month, go with that book. Don't change any book right now, because just a week you are having for your supplementary exam. So only the book which you already learned or already you revised for your university exam, go with that book. No change in the new books, because this will just hamper your recalling power, because you already know the topic. But if you're reading a new book, for your mind it thinks that it's a new topic, and you start to think that you are reading for first time. So this is kind of a psychological game. So I would always suggest that read the book which you read already for your exam. So go with that, revise that topic, so that you don't have to get stressed out. One. Second thing, there are few topics which are very essential in pediatrics, which you have to go, uh, you have to read it before going to the exam. For example, your growth and development. This chapter is very important. And many questions they are asked in your university exam and also in your 1 mark questions. So go with that topic, growth and development, normal growth, normal development. What are the rules of growth and development? Go with that. There are few for 4 points, 4 points for your growth and development. Go with that point. And growth chart. When you go for your practical exam, so many people who get borderline pass or just fail by 1 or 2 marks in practical is that they don't know how to plot this growth chart. So that cannot be told at this short period of time, but I will say, see, in growth chart, whenever you take a growth chart, take you know the age of the child. Most of the time, what happen? You say that the age of the child is 4 years, but actually the age of the child would be 4 years 3 months or 4 years 4 months. So for this, in order to avoid a confusion, always go with whenever you ask growth chart, when you go with this book, I guess. When you go with the so okay. So always when you're going to a growth chart, go with the growth chart. Always take the date of birth. So whenever you're examining the baby or you're writing, plotting the growth chart, always know the date of birth. Ask the mother what was the actual date of birth. With that date of birth, you have to calculate the age. After that, you plot it on the which axis? Y-axis. X-axis, for example, you are taking height for age, length for age. If it's a 2 year child, you go less than 2 years, it's always a length which you have calculated in the infantometer. If it's more than 4 years of age, sorry, for more than 2 years of age, it should always a length, height that has to be calculated. It has to be measured in your stadiometer. So after measuring that, you have to plot the y-axis the age till 5 years. You will be having a month. After 5 years, the age is given in years. So 0, 1 month, 2 months, 4, 6, 8, 12. So for this child, if it's a 2 years, it's go for 24 months. So plot it under 24 months in your y-axis. You put an x in your, don't put it, just give a point in your 24 month in the y-axis. Then the height of the child, if say assume it's 70 centimeter. Okay, the child is 70 centimeter. So from that 24 months, trace upward and put the point in the 24 months. Okay? Sorry, at the 70 centimeter corresponding to the x-axis. So now put a star mark or a cross mark in that point and then see at which centile this percentile is coming. For example, it's coming in the 5th centile, 10th centile, 25th centile, 50th centile, 75th centile, and something. You are assuming that this child's percentile is coming between 50 to 75th centile or between 1 to 2 plus 1 to plus 2 Z score. What does it significant? It is appropriate for that particular age population. So this all Z score are calculated based on that particular age, sex, norm of the general population. So if it's coming between +1 +2 standard deviation or Z score, it means the child age height is appropriate for that age and gender. So in this way, you have to plot your growth chart. Okay. So this is the way growth chart most of the people you get flattered or you get some difficult time in plotting this growth chart. So this is the one thing you have to go through it. Very easy way is you have to plot it. You start practicing to plot whenever you get free time, and then you go to the exam. Practical examination, this growth chart is very important. So in first topic, growth and development, you should always know what is the normal growth and normal development of the child. What are the normal milestone a child has to attain for this particular age group for your four domain? What are the four domain? This is the gross domain, where your fine motor, gross motor, your social, as well as your language. So everything you should learn that 0 months, 2 months, 3 months, 6 months, 8 months, 9 months, 10 months, 12 months. Then like that 2 to 3 months wise you have to go until 5 years you should know. So only the major milestone which is very easy to remember that and always repeat it or you draw it, whatever, which is the way you remember it, you have to draw it. So in that way, you can remember the growth and development chapter. This is very important. Growth and development. Another thing is approach is short stature. That's a diagram that is given in your whatever book. See, this is a simple. So in your OPGI book, if you it's another book I am sharing with you. But if you want to learn this growth and developmental milestone, see the picture that is given in OPGI. This is very simple. For gross motor, it starts from your pull to sit, pull to stand, ventral suspension, axial suspension, and standing. After standing, walking with support, without support, running, upstairs. As a picture format in OPGA. If you go through it every day, it will be very easy to remember. So in this books, you see, for example, I'm showing you. Uh, okay, okay. So if you see this growth chart here, this example, for example, gross motor milestone, which this is shown here. Okay, you see. So newborn, how the child is done. That is limb flex symmetrical force, which is a term beam. After the newborn, when you try to pull to sit, When you see in this newborn picture, there's a marked egg black on pulmonary. This is a major milestone. After 3 months, what happened? The egg control will appear. So when at the 3 months, when you try to pull the baby to sit, the child will automatically come. Automatically, the egg will come forward. This is the important milestone that has to be attained. That is your egg straightening of your head. Okay, right? There must be no age lag so that the neck tone must be improved. So 3 months there will be no age lag. At 6 to 8 months, the child will sit without support. Before at 6 months, he will sit with round back without support. At 8 months, the back will be straight. At 5 months, the child will sit with support in a point tripod position like this. So you know the COPD patient when they try to want to take breath, they will always put their hand in front and they will take your tripod position so that they can take breath. So they can breathe easily. In that way, at 5 months, the child will sit with the support that's known as tripod position. At 6 months, he will sit without support but with round back like this and will straight back at the 8 months. Then 8 to 9 months, the child will start crawling and creeping. So, what is the difference between crawling and creeping? If someone is asking, this is the simplest question. If anyone asks that what it is a crawl and creep. A means abdomen. So, in crawling, the child's abdomen will touch the yeah, exactly. It will touch your ground, touch the ground. Here, the diagram they said crawling as a this creeping as crawling. This is not creeping. This is crawling. Always the child crawls off the ground. Wait. Hello. Hello.
Sir, you're audible, sir.
Uh, okay. So when the child is able to sit, money, what I am meaning, if the child is uh, able to in crawling, what happens? The child abdomen touches the floor, touches the ground, and the child will start to locomote, that the child will move from one place to another. But when the child's abdomen is above the ground and is able to use his hands and foot to move from one place to another, that is known as creeping. This is known as creep. What they showed in this picture is creeping, but they given it as crawling, which is wrong. At 10 months, their child creeping will appears around at the 9 or 10 months. At 10 months, the child will stand independently on its own, but with support. At 11, 12 months, the child will stand without support. At 13 months, the child will walk with support. At 15 months, the child will walk without support. And 16 to 18 months, the child will run. So in this way, if you know the way to understand, if you know the physiology or the pattern of growth and development, you will understand. So what are the four principles of growth for development? Always uh, development. So that is the four parameters. So four parameters always it's occur in a cephalocaudal fashion. It always sequence. There will be cephalocaudal portion and distal to proximal. Yes. Second thing is there will be a sequence. The same sequence will be followed by all the babies of that particular age, but the duration to acquire that particular milestone is different. For example, for one boy at 9 months, he can creep. For another baby at 11 months, he can creep. So it differs, but the sequence is always cephalocaudal and distal to proximal. This is the first point, and it always they follow the sequence. The maturity. CNS must be mature for the acquiring of the milestone. What does that mean? If there is no maturation of CNS, whatever practice the baby you give to the baby, it going to be goes in vain only because your nerves should be mature, it should be myelinated, then only there will be a conduction of impulses. Only if there was a condition of impulse, your muscles will come in action and all this locomotion activity can be done, all the fine motor activity will be done. In other way, if all myelination is proper, conduction is proper, muscle is proper, that's no deformity. But you are not going to practice the child, you are not going to motivate the child, or you are not going to stimulate the child, then also it goes in waste. So CNS maturation must be also there, and there must be a proper stimulation and motivation, so the child can learn to do that particular milestone, or he can acquire that milestone. And always this milestone come from a gross. It will be unorganized way. For example, if you're making a child to catch a ball, you will try to catch a ball or any object with two hands. Once his pincer grasp starts to develop from immature to mature, then you will use one hand first, then you use ulnar grasp. It's your radial grasp. After radial grasp, your intermediate grasp, that is your ear, and then ulnar grasp, and finally your immature pincer grasp like this, and finally pincer grasp like this. You will pick. Like first, you will pick like this with the three finger like this. You will pick like this, and after that you will pick. So in this way, it will develop. So these are the pattern or rules of development. If you know the rules of development, you can easily answer the question and you can easily remember all this parameter what I have. So this is the chapter growth and development you have to learn. And second chapter, which is very important in pediatric, is your neonatology. Most of the people don't read this neonatology very well, or you don't understand the concept. I am already took a class on neonatology. I would request you to go that through that videos. I have elaborately taken that class. I will share the link. All the questions have been answered in detailed format. You can just increase the speed. How you can increase the speed to 2s or 1.5s because you have already learned the topic. Just to revise or to know the concept very well. Main important topic is your preterm term neonates examination, first examination, subsequent examination of the neonate, reflexes, and term preterm babies, low birth weight babies, HGA babies, how to differentiate what are the pathophysiology behind preterm, small for gestation age, and what are the risk factors for the same, and what are the potential complications seen in preterm, low birth weight babies. So we'll go through it, and most importantly, also sepsis, respiratory distress, neonatal jaundice is very important. Someone asked to explain on neonatal jaundice. See, neonatal jaundice, I would rather say to go to that particular topic per se. I will just show the pictures and why the neonatal jaundice is very important. So normally in pediatric, sorry, in adult or any child about 28 days, if any value more than 2 mg per deciliter, we consider the child is having jaundice, and we always treat the child as having a pathological jaundice, and we go with the guidelines given in our standard test. So we treat what is the cause of neonatal, what is the cause of the jaundice, whether it's because of infection or it is because of any inborn error of metabolism, or there's any liver disease, intrinsic liver disease, or the child is having some other complication which in turn causes the liver or hemolytic anemia. What is the cause of this jaundice? Whether it's a pre-hepatic jaundice, hepatic jaundice, post-hepatic jaundice. Post-hepatic jaundice, cholestatic jaundice, which is more in favor of obstructive surgical jaundice. Intrinsic, that is mixed jaundice, both conjugate and conjugate is always go in favor. Liver, intrinsic liver disease, which could be a metabolic disorder or viral hepatitis. And third thing is your pre-hepatic, which is always a hemolytic anemia. What is cause of hemolytic anemia? Whether it is a intravascular or extravascular. If it's an intravascular, what is RBC defect? What is the cause of RBC defect? Whether it's an enzyme defect or it's a membranous defect, and your hemoglobin deficiency. So in this way, you have to decide what is the cause of the diabetes, jaundice. But in a child less than 28 days, The child, either a term baby, around 60 percentage of term baby and preterm to about 80% will develop the jaundice in first 2 weeks of life, which is known as physiological jaundice. What is the cause of physiological jaundice and what are pathological jaundice? So, wait a minute, I will show this. Yeah, this. So, when you see this, what is the reason of jaundice is one is they have an immature hepatic system. So your UDP glucuronidase enzyme, they are immature and okay. NRP. So this is also I have discussed in previous lecture. So yeah, I will be telling a short way how to do it. So when you go with this neonatal jaundice, so neonatal jaundice, as I told you, 60 to 80% of newborn. If it's a term baby, 60%, 80% preterm baby have risk for developing this physiological jaundice. For physiological jaundice, in term baby, it resolves within 12 to 14 days, and in preterm baby, it takes around 21 days. After that, any jaundice that occurs in neonate, we have to treat as pathological jaundice. You should know the difference between the pathology and physiological jaundice, which is already been discussed. And what is the cause of physiological jaundice? One is they have high turnover rate. The RBC get destroyed. What is the reason for destruction of RBC? Yes, the hemoglobin F has to be replaced by the hemoglobin A2. That is the one A1 that has to be done. And the off life of the RBC in adult is 120 days, whereas in children, neonate, it's just 90 days. And also I said it's immature your hepatic system. They're less efficient. Yes, that is the cause of jaundice in that's the cause of physiological jaundice. So why it is important? As I said, neonatal jaundice, any neonatal jaundice that occurs within 24 hours of life or that appears after 21 days of life is considered to be pathological. First 24 hours of life, any jaundice that appears in neonate is is should be treated as pathological. And most common causes here are H incompatibility or ABO incompatibility. And after 21 days, it could be pathological jaundice. Always the physiological jaundice is a unconjugated. Any percentage of conjugation seen at any period of time, whether it's for day 1, day 5, day 8, day 21, 1 mg per deciliter. Any value of direct bilirubin, if it's more than 1 mg per deciliter at any point of time in the neonatal period, should be considered as pathology, and we have to rule out the cause. Do you have to delineate the cause? What could be the cause? It most likely you have to rule out the most important cause is your if the child is you have to see the child whether the child is well baby or sick baby. If the child is well, eating, he has no other comorbidity. If growth is normal, his weight gain is also good, but the content of the bilirubin conjugated level is rising. A well baby whose weight gain is appropriate, there is no other comorbidity except for cold stasis feature. Conjugated bilirubin is more than 1 mg per deciliter, eye colored urine, and passage of clay colored stool. Then there is some kind of obstructive jaundice. The most common obstructive jaundice that occurs in a newborn or neonate or any infant in a well baby always rule out extrahepatic biliary atresia, EHB. And second most, if the child is sick, always rule out your sepsis. Sepsis can cause conjugated bilirubin hyperbilirubinemia. The sepsis, urinary tract infection, or any inborn error of metabolism should be ruled out in a sick baby with conjugation. This is the way. And any serum bilirubin more than 15 mg per deciliter should be considered as a pathological, or any staining of your palm and soul at any point of time should be considered as a pathology. So these are the few points which tell this child is a pathological journey. And then we have to see the clinical feature. It's always non-specific. It could be a poor feeding, the child will have an high-pitched cry, the child will be very lethargic, the child may have a temperature irregularity, and they will these are the few physiology. One day the child will be having some. If the child's bilirubin is more, the bilirubin encephalopathy, acute bilirubin encephalopathy, chronic bilirubin encephalopathy. This could be seen. So this is that way you know this. Another physiological jaundice they can this diagram like this you have to represent in your exam. So in any question has been asked in your exam, always do a flow chart. If you are doing in a flow chart, if you are plotting up the thing in a flow chart or in a diagram like this, which is given in this book, it will be very it will be not much time consuming. You will be saving your time. You're also saving the words, and you will you will make the examiner the examiner will think that you know the concept very well. This is the way you have to write your exam. So you have to write in that problem, right? So, so these are the causes of jaundice, which I said. So, what are the causes of physiological jaundice? Your physiological jaundice is your breast milk jaundice, infection, urinary tract infection, any polycythemia, Crigler-Najjar syndrome. These are the jaundice which are common. So, with the etiology within one day, normally I said from day one, day two till 21 days, it's most commonly physiological jaundice. You should know what is breast milk jaundice or breastfeeding jaundice. Breast milk jaundice and breastfeeding jaundice. One is uh, because of insufficient breast milk. When there is an insufficient breast milk intake, the baby will have a dehydration kind of uh, feature. Because of dehydration, there will be an increased intrahepatic circulation. As a result, there is more reabsorption of the bilirubin, which in turn causes increase in your hyperbilirubinemia. That is known as breastfeeding jaundice. What about the breast milk jaundice? Breast milk jaundice is something the child is having a good intake of breast milk, and there are few substances present in breast milk which causes the deconjugation of bilirubin and causes this increase in the bilirubin uh, reabsorption. This is because of that. So different breastfeeding jaundice is because of insufficient or suboptimal intake of breast milk, leading to dehydration. As a result, there is increased enteropathia. Whereas in breast milk jaundice, glucuronidase like substances are present, which in turn causes your re sorry, which in turn causes the deconjugation of bilirubin and causes the reabsorption of bilirubin. Yeah, as a result, there will be a increased hyperbilirubinemia in that. So this is the way breast milk and breast. There are a few other points which you have to go with the book or any book which you are following. There are 3 or 4 points. This is the important breastfeeding and breast milk jaundice, and what are the way these are clinical features. As I said, the child will have lethargy, decreased feeding, uh, and the child will also have some kind of abdominal distension, sepsis-like features, hypothermia, and high pitch cry, abnormal movements, official tonicity. These go for bilirubin encephalopathy kind of feature. So these are the, and you have to plot in a nomogram. With that nomogram per hour or per hourly basis, we have nomogram for 96 hours, 72 hours that we have to plot in particular to the age. And this is according to we follow initially we followed AAP 2004 guideline, that is American Academy of Pediatrics 2004 nomogram. Right now, in 2022, American Academy of Pediatrics have released, revised this guideline, and they have given a new nomogram. You have to plot in it if at particular for particular age group. So this AAP nomogram is only given for more than 35 weeks of gestation. Below 35 weeks of gestation, for every week we have another nomogram which is given by your NICE, that is your National uh, Institute for uh, Center for Excellence. This is NICE guidelines of UK guidelines. Okay, this is UK based guideline which we follow for preterm babies less than 35. More than 35 weeks, we go in favor of AAP, which they have line. If that particular threshold, if we going below that threshold means the child doesn't require any phototherapy, any treatment, just supportive management. If it is going beyond the threshold for phototherapy, then we have to go with the phototherapy. And there is also a chart for exchange transfusion. If the child's range is beyond that range, then you go with the because this okay like this. This is a this kind of chart. It's given in the I guess in the OP guide. This is a diagrammatic representation. This is not an actual chart. This is a representation. If any value that falls above the phototherapy range, you have to go with the phototherapy. If any value that goes beyond this exchange transfusion range, then you go for the exchange transfusion. And when you plot this chart, there must be serial measurement every 4 6 basis on the severity of the disease. If if you plot serially, you can understand how the phototherapy helps in the treatment. So in this baby, it is serially the bilirubin level of reducing at the point where the phototherapy value go when the value go beyond the phototherapy, two reading you have to take. If it's a non-hemolytic, for it's a hemolytic anemia, at least non-hemolytic anemia causing jaundice. In that case, one reading should be below the phototherapy range. Then you can stop phototherapy and you have to re-evaluate the child after 4 to 6 months. If it's an hemolytic anemia like your RH incompatibility or ABO incompatibility, where your immunity causes the hemolysis of the immunological uh, there is an autoantibody or antibodies causes the hemolysis of the RBC. For that cases, hemolytic jaundice, you have to get two readings below the phototherapy threshold in order to stop the phototherapy. So you should know what is phototherapy. There's another important question. So I have already discussed in that video. Please go through that video, the neonatology. I will share it. Read it. I have explained it comprehensively. So this is the way you have to do a first aid. And another one was this for NRP, National Resuscitation Protocol of 2020 guideline that is given by your American AHA and AAP. What is this NRP? Why this is important? You should know that. This is also I very well explained in that video. I will be sharing. I am just going to show a small chart on it so that you know how to answer. So I'm not going to discuss much on it. Yeah. So this is a simpler chart that has been wait a minute, look up here. Yeah, right. So I will be going with this simple chart. So after that, there are a few questions I will be answering in another that I will be 20 30 minutes. If any other questions you are having, please feel free to put your questions in your group that has been formed. So I will be answering the time whenever I get free and I will just say what to read. You go with that. Okay. So this neonatal resuscitation algorithm, which is a 2020 algorithm, just go with this chart. That's more than enough for this preparation. There's nothing more that is given in the paragraph. Everything that has been given in this chart is the one that is explained here. But this NRP, if you want to learn it thoroughly, you have to learn in person. That is in your institution, wherever you are reading or you are going to do in your internship. When you are doing your NICU posting, you should learn in person. Then only you can understand each and every step that is given in this chart, flow chart. Or else you cannot understand why it is given, what is the importance, why it is arranged in this sequence. Each and every step that is given in this flow chart in that particular sequence is very important and it has to be followed in that way only. You cannot jump to other steps before doing that particular step. So one, two, three, four, five, six. If there are 6 steps, you have to go with that sequence. It has been standardized, it has been formed after many trials and research. So it has to be done in that sequence. There is no jumping from one step to another step. If you're going to do that, it is not going to work. It is going to have a negative impact on the baby. The NRP has been standardized so that each and every people who care for the baby at the time of delivery should follow this protocol in that sequence so that they can prevent neonatal mortality because of lack of resuscitation or birth asphyxia or respiratory insufficiency that happen in the baby by providing the appropriate care that can be they be given in a minimum resource setting. So just going through the chart. So what is this antenatal counseling? Antenatal counseling is a procedure. It's kind of a counseling where before the delivery, the doctor, both the obstetrician and the pediatrician must consult the parent. They have to tell the position, the position or the condition of the baby at present, whether the child is safe or there is some problem or there is some problem you are going to face during delivery. It has to be explained briefly, and what are the neonatal resuscitation you're going to give to the baby, and whether the child is going to be admitted in SNC or NICU for any complication you are anticipating. This has to be very well discussed beforehand so that you are not going to face any medical legal cases in while post delivery if any mishaps happen. If you well informed before to the parents, they get prepared for it. So this antenatal counseling is very important. Then your team. So as per the AAP or this NRP, if for every delivery, whatever be the risk factor or what is the risk associated with the delivery, it may be normal, there is no risk, low risk, moderate risk, high risk, whatever be the risk, one attendant, one doctor, or any skilled person, medical professional or medical attendant who know basic NRP must be present in all in all the delivery, whether it is irrespective of the risk, irrespective of the procedure, whether it's a normal vaginal delivery, low LUCS or assisted vaginal delivery with the instrument. One person must be there before the baby. You should know the basic anatomy. And then, if it's an high risk pregnancy, there's a complication associated with both mother and baby, or there is some anomaly scan was somewhat significant finding it is, or there is some fetal distress, then two people must be there, two or more people must be there. So that is the way where you have to brief your team why you are present in that particular scenario, what is the complication you're anticipating, what are the things we have to do. Each and every person in that team must be assigned for a role. One person is assigned for airway, another person for IVSS, another person for chest compression, like that. Another one person will be a team leader who will be coordinating all the things. And there must be equipment check, which is given in a table, you go with. Then the child, before the child get born, after getting before born, you should know what four questions that have to be asked. What are the four questions should be asked before the delivery to the gynecologist? One thing is whether the child is a term or preterm one. And second, any maternal comorbidities in the form of PIH, diabetes mellitus, maternal chorioamnionitis, or any twin pregnancy bar, whatever risk factor comorbidities, prenatal, postnatal, prenatal, intranatal complications present or not. Third, what is the color of the liquid? Whether the liquid adequate or not, or whether it's the color, whether it's a red, clear, foul smelling, what? And finally, umbilical cord management. As per the recent guidelines, umbilical cord, we go with delayed cord clamping. What delayed cord clamping? After the birth of the child, after the child had a spontaneous breath in the form of a loud, audible cry, the cord must be cut after 30 to 60 seconds of the delivery. In this way, we are going to provide extra amount of 60 ml of blood to the baby, which prevent iron deficiency anemia in the baby, and also the low blood in the baby. It will give additional blood in turn that the iron deficient, and hemodynamically the child will be well. So this is the way you should know the delayed cord clamping for all babies. The only exception, if anyone asks what is the exception for the delayed cord clamping, it would be your resuscitation of the baby or the mother is ill. This is the only contraindication of delayed cord clamping. In other even HIV positive mother, there are few situations where in HIV we don't go with the delayed cord clamping or delayed. It depends upon the status or RH incompatibility, right? So in RH incompatibility, if the child is not immunized, what that does mean? इसका मतलब क्या हुआ? It means that if the child has not acquired the antibodies from the mother, is free from the antibodies, that is the provision of early cord clamping. You have to plumb the child. If the child is already immunized you get immunized, that means the child had received the antibodies against the RBC of its own. The antibodies have been passed the placenta and it reached the fetus, the baby's blood during birth in utero itself. So the child is already sensitized. The child is already sensitized. There is no need for delayed early cord clamping. You can directly go for delayed cord clamping. But the child is not sensitized. It means the child has not received the antibodies against the RBC, is still free of these antibodies, then you have to go for early continence in that case. So after birth, what are the three questions you are asking? Term, gestation, whether the baby is having term, whether the child is term baby, we have a good tone, we have a good flexion and a good cry. If everything is yes, then you should not do anything. Infant must stay with mother for routine care, warm and maintain normal temperature, position airway, clear secretion if needed, dry on being evolution. Now, the okay. So this is the way you have to do. If the child is not this is a routine care. You go with a routine care. If the child is not going to cry, if the child is not crying, is a preterm delivery, there is no good tone, the child is flopping, then you go with the step that is given. Now you have to clamp the cord, bring the baby to the warmer, and you have to warm the child. And then you have to dry the baby with the towel, and then you have to position the baby with in a sleeping dog position, open up his airway, and if you see any secretions present, okay, you have to warm. इसका मतलब कैसे हुआ? If you have to bring the child to the radiant warmer. You have to dry the baby. In the dry itself, the child gets stimulated, and then you have to position the airway so that the airway gets opened up. The larynx come in direct in a straight line with your mouth so that air directly enters the larynx. So the lungs get inflated with the air. And then if you see any secretion, you clear the secretion if present. If present, there is no need for you have to do it has been removed that any uh, unless there is excessive secretion that is impinging your airway, there is no need for doing secretion in all, suction in all cases. Suction is mandatory only in those cases where there is more secretion. After doing this, you have to assess the child. You have to go to assess if the child is gasping or is going for apnea and his heart rate is below 100. If the child started to breathe, he had started to have an audible cry, and heart rate is more than 100, then you should not do anything. Do a labor, and then you assess for whether the child is having labored breathing or persistent sinus. If the answer is there, again you position the airway, clear the airway. If anything is present, SpO2 monitor and supplementary O2 as needed, and consider CPAP, and then go for post-registration care. And apnea or gasping, heart rate below 100. Yes, if the child is not breathing even after doing the initial steps which are given in this thing, then you go for then you go for this step, that is positive pressure ventilation in the form of your bag and mask ventilation, and you have to connect the child to SpO2 monitor and also, if possible, to connect the ECG. You do it for 30 seconds. PPV is positive pressure ventilation. We are going with the help of bag and mask, and ambu bag with a reservoir and oxygen supply connected. Without oxygen supply, without reservoir, without oxygen supply, it can give a room air of FiO2 of 0.21. And if the child is preterm baby, less than 35 weeks, you can start with 21 to 30%. You begin with 21. If more 32 to 35, 28 to 32, less than 20. If it is less than 28 weeks, start with 30% FaO2. If it's 28 to 32, starts with 20, 21 to 30%. More 32 to 35, we go with 21%. If it's not responding, then we gradually increase the FaO2. For any baby above 35 weeks, if the child is not breathing, even after doing initial steps, go with the PPV with the FaO2 of 0.21. That is your room air. After doing this for 30 seconds, you are rechecking the heart rate using stethoscope. If the in all institutes we don't have the ECG monitor available at that particular time, that is why you have to use the stethoscope. If ECG monitor is present, it's always well and good. You see heart rate is still 100, below 100 or not. If no, then go for post test. If still it is less than 100, then go for MR SOPA. What is this MR SOPA? Mask readjustment, reposition the air. Wait, I guess. Okay, I think. Okay, I guess my charger is going off, so I will switching off my this. Wait a minute.
சார் என்னாச்சு சார்? கனெக்ஷன் போயிடுச்சா சார்?
Hello, hello. Uh, Hello. Okay. Sorry for the delay. There was a technical glitch, so I will be again starting. Okay. So, hello, hello, hello. Uh, okay, guys. Hello. Okay. So we were discussing about this topic. So it was in this NRP. Okay. When we're talking about the PPV, this PPV is given to bag and mask ventilation, and we connect to the SpO2 monitor and consider ECG monitoring. When the heart rate goes below 100 per minute, if we go with that particular thing, if it is heart rate improves after PPV, well and good, go with post resuscitation care. If heart rate goes below 100 per minute, if it is yes, then you have to see your technique. If there is a problem in your technique, so what could be the problem in the technique? Either your pressure, you are not giving adequate amount of pressure in your bag, or you are not the position of your mouth, position of the child, and position of the mask is not present, or there is any blockage in the pathway. That is your airway. If this all the 3 points you have to clear. For that only we have a mnemonic called as MR. This MR SOPA is M for your mouth, open the mouth. mask readjustment. Sorry, not open the mouth. Mask readjustment. R is repositioning the head. S for suction. O for open the mouth. P for pressure. A for alternate airway in the form of ET tube or laryngeal massage. Still, after doing everything, the heart rate is not improving. It's and suddenly it goes less than 60. Then you have to start CPR. Before starting CPR, the child has to be intubated. The child must be connected to a cardiac monitor. And the FiO2, whatever be the FiO2 you are using till now, it could be 30% or 21%, 40%, no matter what, the FiO2 must be increased to 100%. After doing all the thing, you have to start CPR in the ratio of 30 is to 2 or 15 is to 1. Whatever be the 15 is to 2 or 30 is to, we go for 15 is to 2 ratio, and we have to continue for this has to be done for 1 minute. We have to give effective ventilation, that is coordinated CPR ventilation. Coordinated ventilation and CPR, chest compression and ventilation. Coordinated chest compression and ventilation for the 1 full minute you have to give. After that, you have to reassess. If the heart rate improves more than 60 minutes per minute, then you stop CPR and continue positive pressure ventilation till the child have a spontaneous breathing. Even after providing 20 to 30 minutes, after giving a 2 to 3 cycle of CPR for 1 minute associated with a coordinated ventilation, the child is still the heart rate is less than 60, then you go for epinephrine. Epinephrine dose is 0.2 ml per kg, 1 is to 10,000 uh, solution, in 1 is to 10,000 dilution. That is given for every 3 to 5 minutes. You can give for 3 to 4 times every 3 to 5 minutes associated with coordinated CPR and ventilation. Even after doing this 3 to 5 minutes, 3 to 5 times of CPR, you are giving an effective CPR, effective ventilation. You are given 3 to 4 doses of epinephrine. Still, the child heart rate is not improving. Then you have to consider two things. You have to rule out whether the child was suffering from hypovolemia or pneumothorax. So, in this way, the neonatal resuscitation algorithm comes into the play. And someone also asked about the acute rheumatic fever. So, this acute rheumatic fever, if anyone asks, tell me, so what is the only one thing which I will be very cautious with this acute rheumatic fever is a rheumatic heart disease. Rheumatic acute rheumatic fever present with how the child present that criteria is known as John's criteria. And this John's modified John's criteria, we have criteria I will be showing you. So I will be just seeing with this criteria. So this John's criteria was, wait,
Sorry, voice is again not clear, sir.
இப்ப கேக்குறாடா? Hello?
Okay, sir. இப்ப கேக்குது, sir.
ஓகேடா. Okay. Uh, wait a minute. Okay. So from recording, so someone was asking about me about the acute rheumatic fever. So acute rheumatic fever. So we go with this rheumatic disease. It's a part of your rheumatic. Acute rheumatic fever, you always also know acute rheumatic fever, what is the cause? It's always a streptococcal. Its age is 5 to 15 years, female predominance, low socioeconomic, everything you know in detail. So what you should know, what is the John's criteria, what is the modification in that, and what is the prophylaxis you use in your primary, secondary prophylaxis in acute rheumatic fever. So for that, we go for this.
சார் உங்க கேமரா ஆஃபா இருக்கு சார், ஆன் பண்ணிக்க முடியுமா?
இல்லடா, கேமரா ஆன் பண்ண முடியாது since I am sharing.
சரி, ஓகே சார்.
Wait, wait a
ஓகே
minute. If possible, I will open.
ஓகே சார்.
Okay, sure. Mm. என் டிவைசஸ் நான் இப்போ டிவைசஸ் பிரச்சனையா இருக்கு, ஸோ ஐ வில் நாட் பி ஷேரிங் இட்.
ஓகே சார்.
ஸ்க்ரீன் விசிபிளா இருக்கா?
இல்ல சார், இப்போ ஸ்க்ரீனும் இது போயிடுச்சு சார், அதனால.
இப்போ ஸ்க்ரீன் இஸ் விசிபிள்.
நோ சார்.
வெயிட் a minute. ஓ மை குட்னஸ், இதெல்லாம் சொல்லி ஷேர் மை ஸ்க்ரீன். சாரி. ஓ ஷிட். இல்ல, இப்போ someone has to allow me to share.
எஸ் சார், பண்ணிட்டேன் சார்.
அப்படியா? ஓகே. Only the host can share in the meetings only. I'm not sure. If a screen visible,
இல்லையே சார்.
still I am not been. இப்போ host இல்லம்மா.
இதோ இப்போ பண்ணிட்டேன் பாருங்க.
பண்ணிட்டியா?
ம்.
முன்னாடியே சொல்லிருக்கலாம், அவங்க சொல்லி கொடுத்தது இப்போ திடீர்னு. ஓகே, நோ ப்ராப்ளம். ரைட். இப்போ விசிபிள்.
இப்போ தெரியுது சார், தெரியுது சார்.
Okay. I guess whatever I taught before that NRP, I taught. Okay, I will be discussing it afterwards. Again, if anyone who have doubt in this NRP, please go to the neonatology videos that has been posted before. So sorry for the technical glitch which was happening for the past 10 minutes. Um, so just I will be going with this acute rheumatic fever, and then also I will be discussing about the just management of bronchial asthma. So this is the thing which I want to. These are the questions people ask me in WhatsApp. So I am discussing that. Okay. Okay, this is the John's criteria. So, rheumatic fever, as I say, after a group A streptococcal infection, more it could be a sore throat, most likely the sore throat. The child, after to 4 to 6 weeks fever, the child will have fever, arthralgia, and some murmur. And features of any cardiac disease. There will be high grade fever with arthralgia, sudden abnormal movements, and you have some rashes on your arm, and there will be a pancarditis or most commonly a myocarditis, endocarditis. With that, the child will be presenting this rheumatic fever. So after rheumatic fever, there are few strains which you already know. So I will just this is mostly we go for John's criteria. Molecular mimicry. This is one of the most commonest because there are few components in your group A streptococcus bacterial wall that against which your antibodies are formed, but these antibodies do a molecular mimicry because there are few antigens present in your heart in your skin, in your brain, and in your joints, which mimics the antigen that are present streptococcal uh, uh, in your streptococcus. So there are streptococcal antigens that are present in the wall of the streptococcus as well as in the cytoplasm of that particular streptococcal bacteria. They mimic some self antigen that are present in your heart walls, maybe your heart walls and your brain, your skin as well as your joint. As a result, the symptoms, the criteria, whichever you see, it's because of this cross reactivity. That is your cross reactivity or molecular immunity. So there are five major and four minor criteria. In 2015, there was a revision that was made that considered a low risk population and moderate risk population. So, what are the low risk population? Whenever there's an incidence of this acute rheumatic fever is less than 2 per 10,000, 1 lakh school age children, and high risk is more than 2. And our country falls in the high risk or moderate risk, low risk. We fall under the high risk population. So what is this guidelines for diagnosis of initial or recurrent of attack of rheumatic fever? That is John's criteria 2015 says the major manifestation is your carditis. Carditis may be your endocarditis, myocarditis, and pericarditis. What is very important? Endocarditis. Second is your polyarthritis. Endocarditis and endocarditis and myocarditis are more frequently formed. Pericarditis plus or minus. Polyarthritis is a migratory polyarthritis. What that mean? What does that mean? Migratory polyarthritis means if one joint is involved within few days, in 1 or 2 days, that gets resolved, and after that the another joint get involved. Most of the time, it's a large joint involvement. Asymmetrical migratory polyarthritis, erythema marginatum, subcutaneous nodal, and sydenham. Minor manifestation of clinical features like arthralgia, fever. Laboratory features are elevated acute phase reactant, that is ESR, CRP, prolonged PR interval, supportive evidence of, and there must be one supporting evidence for an antecedent group A streptococcal infection in the form of positive throat culture or rapid streptococcal antigen test and elevated or increasing streptococcal antibody test. So in this, what are the changes that happen? And carditis is major manifestation, even the echocardic feature is more than enough. If clinically there is no manifestation, if the child is not having any cardiac manifestation clinically, but in echocardiography you have found some endocarditis, that is a mitral valve regurgitation. Mitral valve regurgitation is the most commonest rheumatic heart disease manifestation that is in MS. MS is less, MS and MR. MS occur acute onset. When you go for acute and chronic, in acute rheumatic fever, the child will have a mitral valve regurgitation. If it's a rheumatic heart disease that is occurring after a few years, it is always a mitral stenosis. So you should know what is the difference between the acute and chronic. In the acute onset of acute rheumatic fever, there will be mitral valve regurgitation. But in the chronicity, that is become MS will be the most commonest manifestation of your rheumatic heart disease, that is rheumatic fever. And polyarthritis, in if our country is an risk, even a polyarthralgia is more than enough to say that it can be considered as a major manifestation. Another, they didn't do any change. So that is the given here. That is polyarthralgia or monoarthritis. In high-risk population like our country, the polyarthralgia or monoarthritis is sufficient to classify the major manifestation. And ESR, when you go for ESR, in high-risk population, it's more than 30, it itself is more than enough. But for a low-risk population, the ESR must be more than 60. So these are the modifications that have been seen in your John's criteria. So what are the modifications you are seeing in carditis? Initially, it was only clinically the child must have the endocarditis feature. But even echocardiographic finding of endocarditis is more than enough to say. That is subclinical endocarditis is also enough through the echocardiography to be fulfilling the major criteria. And when you go for polyarthritis, this must be fulfilled in a low risk population. But high risk or medium risk population like our country, even a monoarthritis or polyarthritis can be taken as a major main criteria. Eczema marginated subcutaneous nodules and chorea are other features that has to follow. In minor manifestation, clinical features like arthralgia, fever is same. This arthralgia, in case of low risk, it is polyarthralgia. High risk, it could be a monoarthralgia. Fever is 100.1. That's the temperature, I guess. So there is no particular temperature given for fever. Fever most likely we take 38.3 degrees Celsius or 100.1, 100.101, or in some books it's given 100.3 or 101 degree Fahrenheit. In our elevator acute phase reaction, that's some change. ESR, if it is more than 30, in case of a high risk population, it can consider taken as high ESR, but for a low risk population, it should be more than 60. So for initial attack, two major or one major plus two minor criteria with the supporting evidence of previous group A streptococcal infection must be present. But in case of recurrent attack, two major or one major and two minor or three minor is more. And this three minor must be present if the child is having, we follow a high risk population. So these are the modified Jones criteria. And what is the drug of choice for the prophylaxis? It's your benzathine penicillin, and you should know the values that has been given in the book. So this is this picture where you see a polycyclic evanescent raised lesions. Okay, this polycyclic red border of erythema marginatum in febrile child with your acute rheumatic fever. So you see in acute rheumatic fever, this is the raised lesions with the annular lesion, polycyclic annular lesions with a raised red margin. The typical features of erythema marginatum that are seen in your acute phase, in acute rheumatic fever. Okay. For this prophylaxis, see, this is the prophylaxis. We go for secondary prophylaxis. Treatment is always with your benzathine penicillin. That is your first primary prophylaxis. But what is the primary prevention you do? So you give an antibiotic treatment. Is well 10 days antibiotic should be given your oral penicillin, or so what you give? So you go with the oral. The patient should receive 10 days of orally administered penicillin amoxicillin or a single ionization of benzoyl penicillin to eradication of gas from the upper respiratory tract. So the antibiotic therapy is given for what? We are not given for the treatment. We are going to eradicate the bacteria. That is a major reason, eradication from the streptococcal, because already the damage has been done. And the damage that is being done to the body, your carditis or your myocarditis, endocarditis, your sydenham chorea, your skin lesions, your arthritis is all because of immune mediated lesion, not because of the bacteria per se. So you're by treating the bacteria, not going to and not we are not going to treat the cause. The immunological manifestation has been done cannot be removed by just treating the bacteria. You are treating this bacteria, killing this bacteria, or you are removing the colonizer. You are removing this, eradicating the gas from your necessary only to prevent the further antibodies production. So in short term, it means that you are eradicating bacteria so that immunity for that bacteria, one thing it will increase, but the second thing, or antibodies production will be decreased because the bacteria has been removed from the system by the antibiotics. So the immune response against this bacteria will be reduced. So there will be no production of the antibodies. So there will be no molecular memory. So the symptoms start to fade up. That's the reason why you are going to give this benzathine penicillin. Either you go for oral drug or single iron benzathine penicillin. If a patient is allergic to penicillin, you go for 10 days of erythromycin, 5 days of azithromycin, or 10 days of clindamycin, whatever drug that is available. And since a child will have arthritis, severe pain, you go with an MSID kind of anticept, like you go for always we treat with aspirin. So aspirin, the dose is always reviewed for 50 to 70 mg per kg day in 4 divided days for 5 days, followed by 50 mg per kg per day in 4 divided days for 2 to 3 weeks, and of that dose for another 2 to 4 weeks. So in this way, you have to treat the for your for arthritis and arthritis. So what about the secondary prophylaxis? I will simply say when a drug that is penicillin G benzetine 6,000 if the child weight is less than 60 sorry, less than 30 kg. The child weight is less than 30 kg, you go with 6 million international unit for children weighing less than 30 kg. If it's more than 30 kg, you go for 1.2 million international unit. For people who are allergic to penicillin, you go for macrolide like your azithromycin or clindamycin, or you go with your erythromycin. That has to be clear. These are the drugs which you give for secondary prophylaxis. And what is the duration of prophylaxis? Prophylaxis is rheumatic fever without carditis, 5 years or until 21 years of age. Rheumatic fever with carditis but without residual heart disease, you go with 10 years or until 21 years of age, whichever is longer. Whichever is longer, if the child age is 10 years and you go for 15 years, till 15 years I can give, but or 21 years of age. So till 21 years of age, you have to give this drug. If the child is having rheumatic fever without carditis, if the child is having carditis feature, but there is no residual heart disease, there is no residual stenosis or like mitral stenosis, you go for 10 years prophylaxis or till the child age become 21 years, whichever is longer. If the child is having rheumatic fever with carditis and also having residual heart disease, go for till 40 years, whichever is longer, and sometimes you have to give lifelong duration for the secondary prophylaxis. So this is the thing which I want to say for your acute rheumatic fever. And finally, I will complete with this bronchial asthma treatment. So, like this, bronchial asthma. I will be concluding. Okay. So the management of asthma. So whatever they asked about the management of asthma, so we will see the asthmatic attack. That is the asthma that present in your emergency. That is your status asthmaticus. So just the teaching. So Okay, this is the term. Okay. So, if any child comes to the OPD or in coming to emergency department, you are seeing a child. Most of the time, if any child come to the OPD or emergency department, they always complain with the chief complaint that child is having wheeze, because most of the parents know that child is suffering from wheeze because most of the children are getting intermittent nebulization and outdoor management in medical college or any hospital. They go whenever most of these attacks appear during early morning or at late night, where they visit the ER and the child get nebulized with ipratropium bromide or acetylene and with butyrol and giving a stat hydrocor. After that, the child becomes that bronchoconstriction get, since bronch get reversed and get relieved, the child start to have a normal breathing, and within 30 to 40 minutes, child is sent back to the home with some oral medication. Still, they have this recurrent attack. So whenever a child comes to the OPD or to the ER, you have to assess the complaint. Main complaint will be a difficulty in breathing, chest tightness. This is the most complaint the child comes to you. Now, I am talking about the red zone. I'm not going to talk about it because acute status asthmaticus, if any child, the child, what are the symptoms they will be present? They will be have, they cannot complete a sentence. They will have a difficulty in breathing. They will have increased work of breathing in the form of nasal flaring one, and there will be increased retraction, suprasternal retraction, subcostal retraction, sternal retraction. They don't cannot talk, they cannot drink, and they will be very anxious, they will be very panicked because they think they are going to die. So they will have some that kind of ominous sign. So this all tells they are we are impending respiratory arrest because the airway are completely constricted because of the mucosal thickening and with the vasos constriction, that is your severe bronchospasm. So there is no air entry and there is air trapping. As a result, the child is having all the symptoms which I told you. So they have very hard time breathing, constant coughing, trouble walking or talking. They cannot complete sentence. They become cynos. There will be supraclavicular, suprasternal retraction. Even after, in these cases, if you give albuterol, that is your salbutamol, levosalbutamol, which they cannot relieve symptoms within 10-15 minutes. Normally, giving albuterol within 5 to 10 minutes, the child gets relieved of symptoms. But here, after giving albuterol, also the child is not improving. They may have wheeze or without wheeze. If any child who is not improving the albuterol and the child chest is clear, it doesn't mean that child is not having asthma. It is the severity of asthma. If the child having severe asthma, that's a severe bronchospasm, then there is no way the air enters the chest. If there is no airway entering into the airway, you are not going to have that typical wheeze. Instead, the chest will be clear. Your child is not good, not well, but the chest is clear. It typically means he is having a silent chest. Silent chest. It it means the child will go into a sudden respiratory arrest. So you should be very cautious. You have to clinically assess. If the child is playful, improved after giving albuterol, and the chest is clear, that is different. One is the child has responded to the treatment. You have given the albuterol, but the child has not responded. The child is lethargic, is he cannot talk or his answer blue, but chest is clear. That is different. In that indicate the child having a silent chest. That's a severe bronchospasm. If you're not going to treat that child immediately, the child will have a sudden respiratory arrest, and that in turn go for cardiac arrest. So you have to see these are the silent. If this is present, child should be instruction to the patient is you have to give 4 to 6 puffs of beta glucose, that is salbutamol, in the interval of 15 to 20 minutes. One. Second, okay, I will be just briefing it. Yes. Then you have to start injection hydrocot. We have to IV assess, line IV assess, give an IV hydrocot 10 mg per kg per day, per 10 mg per kg stat. Then you have to give salbutamol in three along with ipratropium bromide 20 minutes interval three times with along with hydrocot stat dose should be given. You have to reassess after 60 minutes. If it's not improving, then what you have to give, you have to go for another cycle of ipratropium in the same way. You have to give Maxelf at a dose of 0.1 ml per kg. And then if still the child is not improving, you go for terbutaline or or else you go for aminophylline. Giving aminophylline of loading dose of 3 to 5, 5 to 7 mg per kg stat, followed by 3 to 5 mg per kg per hour. So you should, for in that way, you have to run and then you have to assess. Even after the child is not improving, then you have to intubate the child and we do the whatever the procedure. This is the way you have to keep the any child who have asthmatic attack. Meanwhile, you can, if the IV line cannot be assessed, the child is having severe bronchospasm, then you have subcot adrenaline 1 to 1000 dilution of zero point 0.1 ml per kg, 1 to 1000 dilution of subcot adrenaline that can be repeated 20 minutes once for 3 times till you have an IBS. This can be done. So in this way, first you give 3 times nebulization with salbutamol along with salbutamol with ipratropium. In the meantime, we have to give an IV hydrocodone assess after the 60 minutes. If the child is improving, well and good. You go with tapering the ipratropium and your levosalbutamol as per the rule. Then, as per the guideline, if the child is not improving still, then you give another dose of. If you may try, if the child is somewhat stable, you can give another trial of your salbutamol, or you can go for the ipratropium. If still is not improving, then you go for a max self infusion. Then if not improving, then terbutaline or aminophylline, whatever is available. If then also is not improving, then you have to intubate the child. So this is the way you have to start the status asthmaticus. So with this, I complete the class. I hope you got some insight about the important questions which have been asked. Any doubt or any doubt in any topic in pediatrics, feel free to post in the group of medicine. So whenever I will available, I will be messaging that topic and I will also share any relevant pictures, flow chart, which is very easy to replicate in your exam so that you can uh, gi- give your best in the upcoming exam. So with this, I end the session and I would like to thank Raghunandan and uh, Parthiban for providing this opportunity. So, any questions or any doubt, I'm here to help you. So, I'm wrapping up the session for now. Good night, again. Thank you.
Thank you so much, sir. That was a very elaborate and wonderful session. We are looking forward for your next session on Monday. Students, don't forget to join for the next session on Monday about nephrotic syndrome. Thank you so much, sir. Thank you so much, sir. That was an amazing session.
Sure, sure, sure. Thank you so much.